Okay. So Dr. Zadeh received his Doctorate of Dental Surgery degree from USC at Oxford School of Dentistry. He has also completed advanced clinical education in Periodontal and earned a PhD degree in Immunology from University of Connecticut, Schools of Dental Medicine and Medicine. Dr. Zadeh is internationally recognized for his clinical and scientific expertise. His clinical areas of interest range from static and minimally invasive periodontal and implant surgery, as well as tissue engineering. Dr. Zadeh directs the laboratory. I guess you tell me. So Dr. Zadeh is a director of American Academy. He's a Dr. Zadeh. I'm sorry, I missed this
Don't
up.
worry.
Just give me a whole resume of you to read here.
You know what?
But you know what? Let me
Just
say
talk.
my own
We don't
words
need
for you.
to
Let me
do
say this in
intro.
my own words. You know, I think this I wrote for you, Dr. Zadeh. You know, every once in a decade, you come across an individual who has shown such excellence in their field. An extraordinary human being, a devoted family man, passionate and a remarkable educator, an exceptional innovator, an extraordinary inventor, and a first-class clinician. Dr. Zadeh, welcome.
Thank you, Kevon. It's really a pleasure to be alongside my longtime friend and colleague, Dr. Kevon Javid, and I want to thank you for facilitating this to join with colleagues and friends from all over the world. So it's a pleasure from wherever you are who are tuning in during this very extraordinary period in our history to have a chat with our colleagues on a Sunday. So it's my pleasure to talk with you and just share some of our clinical experiences and information with the colleagues from around the world.
It's our honor and a pleasure to have you, Dr. Zadeh. So today we're going to be talking about basically VISTA techniques, doctor. And most people, when they look at VISTA, they think this is only for teeth. So does it work on implant? Is that something that do you?
Mm-hmm.
So you're going to be presenting something to us for VISTA, for periodontal and peri-implant plastic surgery, improving health and aesthetic around teeth and implants. Again, so most of the time, when you look at, there's so many of this, of course, this tunneling technique and all this different people come up with different names for this, and they patented this and that. But basically, can you give us a little bit of information on how your technique is different than theirs?
Right. Well, I will be showing specific information about that, but just as a general concept, periodontal and peri-implant plastic surgery are techniques that are intended to improve the function and restore health and comfort to patients who've had destruction or damage to the oral tissues, whether it's periodontal tissues or peri-implant tissues. So it's a reconstructive procedure. Basically, the inspiration is that if you are a plastic surgeon today, plastic surgeons do many procedures to enhance aesthetics, right? But that's not all of plastic surgery. Plastic surgery is intended to restore health and comfort and bring patients to an original state. What we see happening in Beverly Hills or in many parts of the world where people just want to change themselves, that's not really what the original intention of plastic surgery was, right? Plastic surgery is intended for somebody who's in an accident, who has burn, who has surgical resection of parts of the body, to bring them back and make them whole again. So if you think about periodontal and peri-implant plastic surgery in that way, that you want to make people whole again, you want to bring them back to where they were at one time, rather than making an just to do something cosmetic or surface. That is something that you can think about. So what do we know about plastic surgeons? Plastic surgeons are basically want to make their transformation in ways that nobody will be able to tell that they had surgery done, right? So they do that by really paying attention to blood supply. They're paying attention to biological concepts. So to the extent that we want to have this kind of a concept, I think like plastic surgeons do in terms of oral reconstruction, that's how we can think about bringing patients to the original state, whether it's around implants or teeth. So when we started to develop the concept of VISTA, that's one way. But, of course, I am very much biased in the way that I view that, but doesn't mean that that's the only way. And I'm the first one to acknowledge that there are many colleagues and talented clinicians around the world who manage it from different views. So we can always discuss and debate what are the differences and similarities.
Sure. So Doc, I've tried many different ways, and the way your procedure works with VISTA, since you have a bigger opening, I think it helps a lot. With less traumatizing the periosteum and the tissue around. So I think that really makes a big difference. Patients' comfort, post-op pain, all that. So, Doc, I know right now you guys are. By the way, so you have a PhD in immunology, Doc. So, what was going through your mind, and what did you want to do during this COVID-19? I always thought, if there's somebody I need to talk to, is Dr. Zadeh, because I'm sure he's, So, what was going through your mind?
Well, I think that really brings back what we know about immunology and how your immune system is intended to protect us. And I see that there's a lot of unknowns about this because a novel virus, people wondering whether or not you can catch this virus once, you can catch it. And if you do get infected with the virus, why do some people have a terrible outcome, others have a very good outcome and barely have any disease? And how long will we be immune from it once we are infected with it, whether or not you can be infected more than one time? So there's a lot of unknowns about it. But what it seems that, yes, there's definitely, just like any other disease, there are risk factors. There are risk factors, some of them that we know about. Inflammation seems to be the very important risk factor here. So anytime, and this actually shows through in many parts of infection, including periodontal disease and other oral infections. It's not so much that it's the virus that's causing the disease and death. It's really inflammatory response to the virus that is causing people to go on ventilators and pass away. And that's really the key. The common denominator is inflammation. So that's the common denominator of diabetes, periodontal disease, cardiovascular disease, all of these. So once we figure out why do some people have an extraordinary inflammatory response and others do not, I think that's something that we can much better manage these people and manage the risk factors.
Thank you, Dr. Zadeh, for explaining that. So let's tie this into, the education. And I know a lot of meetings and associations, they all postponed their gatherings, and a lot of courses were canceled. What have you done, to change after COVID-19, your courses and your educational programs?
Well, the first thing that we have to do, that this is really an extraordinary moment in time for all of us. We have two choices. One is to kind of just sit at home and just be sorry for ourselves and think that we are a victim and we're all going to have our lives shattered, or we can try to think about innovating and coming up with new ideas and trying to go forward. So I personally believe that this COVID-19, as bad as it is, it's going to be succeeded by a period that we'll never have seen in the history of humanity in terms of innovation and creativity. So I think that we will see in the next few years, there's going to be a lot of ideas, and so I urge all of our colleagues to put your mind, creativity to whatever you're doing to try to advance. So what we've done in terms of what we were doing is to rethink and reimagine how education has been. We've really enjoyed, I've enjoyed myself traveling all over the world, meeting with many colleagues in different countries and different places, and providing education in many different areas. So in a given year, I was traveling to dozens of countries. Of course, we can't do that right now. And we had many people come to us at our institute, at the VISTA Institute in Southern California. So people are also hesitant to travel these days. So what we've done is that education should not stop. So we have two types of educational model: synchronous and asynchronous model, where synchronous means that colleagues will join us live, and we'll go through, like right now, we are all synchronous. We're listening to the same discussion, and it will be live. So people have an opportunity to participate live in our not only lecture, but also workshops. And to that, logistically, it's a little bit more complicated, but we have been shipping our kits and models and all the material they need to follow simulated exercises at home during this period. So we will ship models and all the materials, so you'll be able to follow along in real time and live to learn the concepts and also the actual hands-on skills. But also we augmented by on-demand materials. So that's what we call asynchronous. So you'll be able to, on your own time, listen to the theories and follow along the ideas, the past research, scientific evidence, and background, so you can basically access it on demand. So people can actually go to our website, learnvista.com, and they'll be able to see some of these courses that we have offered in the past, or we have coming up that will be able to actually pick up a new skill or enhance their skills.
That's amazing. Dr. Zadeh, I personally like this much better. I always say that, COVID has brought some, obviously the disease is a bad news, but it has brought some really good stuff around. As far as hygiene, people being clean, and, the cleanliness, and, but as far as education, I think this is so convenient. Like you said, you can sit home. You don't need to get dressed and travel, and you can do the whole thing at home at your own convenience. Whenever you want to do it. So that's amazing. Well, congratulations for setting that up. That's amazing. I know a lot of people are trying to do that. So
thank you.
So Doc, what about going back to VISTA, and maybe you can tell us a little bit more about the whole ideology of it, and the concept, and I know you've invented your own instruments, and maybe you can show us how you use those, or how they're beneficial.
So if you think about basically a plastic surgical approach, you think about what plastic surgeons do. So if you want to get a facelift, would a plastic surgeon ever put incisions right in the area that they're trying to correct? No, that's not what plastic surgeons do. Plastic surgeons are about concealing the evidence, concealing the access point, right? Putting the access point remote from the area that is being treated. So when I look at many of the plastic surgical procedures, that involve making an incision directly in the area of papilla, directly in the area of the gingival margin or mucosal margin, that is actually goes contrary to plastic surgical techniques. So the first thing is to think about remote incision, creating tunneling. So tunneling can be great. So if a plastic surgeon does a facelift, typically they make an incision behind the ear, then they tunnel forward. But tunneling shouldn't mean blind. So when I see some of the tunneling techniques where they're just puncturing the tissue and just stabbing at it, you know, they may have a really small initial, hole, but they basically essentially doing blind. And just because access to the skin is, minimum doesn't mean minimally invasive. So you won't see a plastic surgeon just keep stabbing the face with different areas blindly. They would make a clean incision so they could create a tunnel that gives surgical access and also visual access to the surgeon to be able to correct what they need. So that is the concept behind VISTA, making an incision usually in the vestibule, which is the incision area. It's going to be wide enough to give surgical access. You think of VISTA as creating a window so you can actually visually see, not just something to put your instrument through. It's something where you can actually create it, and that's what we call the VISTA, because you have a vista or a view of the area that is being treated. So you should have direct surgical access. You should have a window to see whatever you need. So that's just an access, right? So then what you do with it, you can actually use it for regenerating the periodontium, whether it's a bony defect, like guided tissue regeneration, or just a recession defect, such as the root coverage technique, or implant thread exposures, or trying to manage extraction sockets, trying to place implants, trying to do bone regeneration, alveolar ridge augmentation. All of these are possible through a vestibular access that is remote enough, but also preserves the blood supply over the surface, but gives the surgeon visual access and surgical access to put the graft material that they need, do the manipulation that's necessary.
That's amazing, Dr. Zadeh. I've tried this firsthand myself with other techniques, and I know exactly what you're talking about. It's almost impossible to go through those little holes and carry things in there, even if it's collagen. And you're definitely damaging a lot of tissue underneath, because you're obviously not seeing where you're going, and there's almost impossible to access where you want to without hearing the tissue or the periosteum or the structure around there. So I think that's really genius stuff, to be able to open up. Do you make more than one incision, or do you?
You can have as many incisions as you need. So it depends on what area you're approaching, what are the limitations. So it's not really about whether you make one or multiple. If you need it, by all means, go ahead and make it. It doesn't really have consequence because it's from a vestibular side. So sometimes we make one incision if we're trying to root coverage and the access is wide enough, and the instruments that we have curvatures that kind of follow the curves of the arch, and you can actually follow that. Some procedure that we do, let's say corticotomy for ortho, those we need to have direct access. So we make multiple of these incisions because we really have to see in between the roots to make those corticotomy scores. So we make a number of incisions. So there are not really no consequences to making more than one incision. But the key that I emphasize is because you're making an incision, you can actually have these instruments that are actually wide enough to get under the periosteum. And that's really the key, because people think about tunneling instruments as being little instruments, but little instruments are very inefficient because they're intended to work through small areas. We actually make fairly large instruments that are very efficient, it can work quickly, but you have to get under the periosteum because our goal is to separate the mucosa and periosteum together. So if
Right.
you separate mucosa and periosteum together, you have intact blood supply and the blood supply is not interfered. But if you're
Right.
working through a tiny area with tiny instruments, what you're going to do, you're going to keep stabbing through the mucosa and periosteum, and you got to get into the submucosa. So what's in the submucosa? You have blood vessels, you have nerves. So that's why many times we see, as a result of some of these blind surgeries, paresthesia, we see actually vascular compromise because the submucosa was penetrated. So if you can get under the periosteum and keep the mucosa and periosteum together, you have great blood supply and you have actually much less invasive procedure and much faster healing.
That makes sense. Totally makes sense, Dr. Zadeh. Firsthand, I've used those other instruments, and those little instruments beside just causing problems underneath. You can also easily get punctures through, so you can have areas of defect or dehiscence, on the outside where whatever you're putting in there, and the patient will have a lot of obviously discomfort after. So that's great. That's great.
Well, what I'm really proud is to see many colleagues from all over the world doing research on this, especially in India. I've had the privilege this week reviewing a research that was done by some of the colleagues in Pune in India. There have been, I think, a dozen research on VISTA from India, in Spain, in Portugal, Brazil. Many colleagues are doing research, and that's the key, that we basically open this up, the concept. We don't close them. We don't try to prevent people from research. We encourage people independently to go ahead and do their research and publish, and that would be the best way to document the efficacy of various procedures.
That's great. That's great. That's amazing, Doc. So, Doc, I've watched you do Vista, and I've watched you do grafting at the same time using your own. I know you have this mod fix, these screws that you've invented, which are amazing, by the way. But so you can do a Vista, and then you can do a distal grafting on a ridge at the same time through that tunnel. That's
right. Well, I have to, we have to always give credit to people who are actually pioneers and innovators of various procedures. So I have to give credit to my very good friend Fuad Khoury from Germany, who has been one of the pioneers of this concept. So this wasn't my idea. Fuad Khoury, decades before, started doing the vestibular tunneling and doing bone augmentation. And those of you who are familiar with the Khoury technique, you know that he uses big shelves of bone. He harvests autogenous bone using microsaws, and he installs these big shelf of bone and the particular bone in between that. So he, is able to perform all of this through the vestibular tunnel. So he is basically, I think, should be credited with pioneering the idea of vestibular tunnel for bone augmentation. Also, we should mention Michael Block, who also pioneered particulate grafting through the vestibular approach for bone augmentation. But it's unfortunate many colleagues today, they pretend like they came up with all these ideas on their own and nobody else existed before that. So I just think it's very becoming to acknowledge those who come up with ideas before us, because we all are, learning from each other, and we all are basically drawing inspiration or ideas from those who preceded us. So I think definitely bone augmentation through the vestibular tunneling is complicated. I wouldn't minimize it. It's very challenging surgically. I would say that it's not easier. It is more technically challenging, but it has some biological benefits of not having incisions in the surgical area, so you would have better blood supply to the overlying mucosa.
Right, right. So, Doc, can you also through VISTA, you're able to actually, so when, if you have an implant that is, and we see this a lot nowadays, right? I mean, we didn't have this, 10 years ago. You would hardly see people, most people will come to your office, you wouldn't see an implant in their mouth. Today, when people come in, I would say maybe 50 to 75% of our patients at least have one or more implants in their mouth. So we do see recession and we do see threats showing, in these patients, and obviously, as you know best, I've removed implants for other patients, and I know it's one of the most difficult procedures. If you're gonna basically have to destroy around that implant, even if it's just a couple of millimeters that is attached. So the best idea sometimes is just to basically keep that implant and do something about the recession. So VISTA can help with that.
Well, it is true that more and more we find not just healthy and intact and pristine implants, but as the number of implants that are being installed today are increasing, so are the problems and diseases and conditions from problems with implant, both functional, inflammatory, and aesthetic problems with implants. And we should be managing those. First, we should be diagnosing them, and we should be managing them. Yes, there will be opportunities to use soft tissue augmentation around implants through VISTA. There's also opportunities through VISTA to make bone augmentation around implants, although I would say that the predictability of regenerative techniques around implants is lower because we have worse of a blood supply around implants, and it's been more challenging to decontaminate implant surfaces. So we should give thoughts about that, about prognosticating implants. If the facial aspect has threads exposed, has recession, then thinking about soft tissue augmentation, I think that may be something worthwhile to consider for implants to try to correct the mucosal deficiencies there. But if there are intraosseous defects around implants, then bone augmentation may also be indicated. Both of those are possible through VISTA approach. And then when you have bone loss all around, and then you have to do the risk assessment, and sometimes you have to actually explant and start all over again.
Right. Great. Thank you, Dr. Zadeh. So, would you want to maybe explain a little bit more about your virtual hands-on programs and exactly? So you said you send in a kit to the house. Is that a live session, or is that are you doing that in a live situation?
You have both. You have the opportunities. All of our courses will have some element of on-demand asynchronous learning, which means that, for example, you don't want to sit and interact with the screen at the designated time because people are in different time zones and it's not always convenient to do that. But also when you're hearing a lot of theories and scientific background, you only have so much attention span to take all of that at one time. So what we try to do, we put a lot of the theoretical aspects, scientific evidence, background information on our website so people can access and can learn on demand at their own pace. So you can maybe 1 hour a day or something like that can access the online information on your own time and just listen to it. And we also provide the actual scientific papers on our site so people can read that evidence if they would like to. And then so when they actually participate in the live lectures and live workshop, they already have the concept, they already have the fundamentals. Then we can get right to the surgical aspect, prosthetic aspect, learn about the clinical aspect, and then give the hands-on instructions. So for many things it's possible because we've assembled the kits and the components and the simulated model. My dear friend Fernando Rojas Vizcaya in Spain, he has this company called Bone Models. He has made these customized models that are perfect for each of the realistic simulated exercises. So we utilize those and we ship those along with everything you need to follow along with the workshop at home during that. So you'll be able to follow along. And if that time is not enough, you have the access to the recorded workshop instructions, so you can go back and do the suturing technique, do the tunneling technique over and over until you become proficient at it. And then if you want some feedback, you can always take photos, take little short videos of what you're doing, send it, and get feedback on that.
That's
so this
great.
is possible anywhere in the world. So if anybody who's listening in and wants to participate, you just actually, if you go to our website, you'll be able to chat with us. You have a dental chat. It's also another module that we have on our website. You can put in your chat questions, information, and you'll be able you'll get a response promptly to that.
So, I mean, again, being through so many of these courses personally, and I know exactly what you're talking about when you go sit there. And a lot of times we don't pay attention to those details. And when we go back to doing it, and we see, hey, you know what? Where should I put this incision, or how am I gonna take this incision all the way to the attached, keratinized tissue, or should I leave it, or how many millimeters before, or what type of suture, or exactly. So the participants would have the opportunity to first review everything and then come back and ask you if they have any questions, or right.
So when you're coming to the live session, you already have heard the theories, you've heard the information, you've formulated some questions. So during the live sessions, you're able to ask the relevant questions.
Got it. Awesome. Perfect. Well, Dr. Zadeh, I think we're coming to the time where you do have a presentation for us today.
Of course.
Yeah. So I guess if there's going to be some questions at the end, I'm sure if I'll ask you when they come up. But if you want to go ahead and start with your.
Sure. I'm just enjoying talking with you.
Oh,
but
thank you. No, me too. Absolutely. No, I love it. Yeah, thank you, Doc.
I'm happy to go ahead and give the information. Yeah.
Sure.
So do you want to go ahead and put that up? Very good. So I will be. So do you have my screen? Are you able to see that?
Yes, we can.
Okay, great. So the first thing that I would like to show again, I give a shameless plug about our website, learnvista.com. So if you really want to get more in-depth information about this, feel free. But I want to be very transparent that I do have conflict of interest with many of these because I have a company that makes some of these devices. Dr. Javid mentioned ModFix and Unifix fixation screws. These are the ones that I developed and patented and distribute through Mectron or Piezo Surgery in the US. We made these premium closure sutures, the VISTA instruments, and I've worked with a number of companies. So yes, there are disclosures that I'd like to be very transparent about it, so there's no misunderstanding. So periodontal plastic surgery, we already talked about it, talking about giving credit to colleagues, Pat Allen and P.D. Miller, treatment of gingival recession, vestibular deficiencies, contour deficiencies, peri-implant plastic surgery, giving credit to Massimo De Santis and Clementini, who came up with this term for the first time, and basically correcting malposition implant situation, extraction sockets, and implant-related recession. So I would like to just take you through a case of talking about the VISTA for treatment of gingival recession defect, just so we can learn about how the procedure works. So this is a patient, typical patient, has not just one tooth, have multiple gingival recession defects. It's not just one area. So yeah, what I see is colleagues offering one tooth at a time. I don't think that's the best, because you want to manage all of it at one time. And many times patients' chief complaint is these black triangles that they hate. So we'll address that as well, but also exposed roots with the sensitivity, also showing the margins of restoration. These are some patient-related complaints. So the first thing that we start with is the root, treatment and root reshaping. And that's a very important aspect of this procedure, because let's say I spend almost half of the time of the procedure in reshaping the roots. And this, if you take nothing away from this presentation, whatever technique you're using is fine, but reshaping the roots is very important to get rid of a lot of the root prominences, and we'll talk more about that. And then the vestibular incision. So remember, VISTA stands for vestibular incision, subperiosteal tunnel access. So we make an incision in the vestibule, and typically the key is to make the incision starting away about 5 millimeters from the gingival margin, because you don't want the incision to rip into the gingival margin. So it has to be apical enough, but how long you make it, it depends on what you need. There's no problem with continuing this incision higher and higher up. So the challenge becomes in cases who have short, shallow vestibule, you don't have as much room up here, but it will give you enough access in these cases to be able to create a nice access. The next thing is you want to make a subperiosteal tunneling. Subperiosteal tunneling means full thickness access or full thickness dissection, mucoperiosteal, which is the key, because you want to keep the mucosa and periosteum together with this subperiosteal tunneling. So subperiosteal tunneling uses relatively larger instruments to get underneath the periosteum to separate the mucoperiosteal complex from the underlying bone. And we extend these under each of the papillae. So we have papilla elevators that get underneath that. And remember that odontoplasty or root reshaping is a very important aspect of it. So I usually start it before the tunneling, and then I'll continue it after the tunneling, because once you have the tunneling, you have the opportunity to retract the tissues and continue this root reshaping or odontoplasty subgingivally. I want you to also notice that in this area, I've made the reshaping of the crown margin and restoration, because previously the restoration extended all the way to the gingival margin and it was quite bulky. So that's really important. So if you think about the bulge or the bulkiness of this restoration, you can imagine that tissue does not want to go over this bulge, because that bulge is like a wall to the cells. The cells cannot climb over that wall to get to the other side. So what we do, we make it easy for that. So we create a flat or concave surface, so then the tissue and cells can grow into that space. So you can imagine and see how much I removed from the restoration as well as the roots. So on this side and on the other side, I've removed this bulky composite restoration. No restorative material belongs on the roots. We try to keep restoration in enamel, and in the cervical area, we try to cover it with soft tissue. Okay, and so you can see on both sides how much odontoplasty we've performed, and that's what it looks like. So that's really the key for making that, and I emphasize again the importance of this odontoplasty as one of the key steps for success of root coverage procedure, no matter what technique. You can use whatever technique you like, that's fine. There are many colleagues around the world who are using different techniques and getting excellent results, but the root reshaping or odontoplasty is an important step. The next step is the suturing. The suturing is really, really important. Why? Because first of all, we need to coronally advance the tissue. And you want to coronally advance it to the point that you, as a surgeon, want to control, not just whatever you can do to accomplish that. So you can see that we create harmony of the gingival margin, and you want to keep that area stable. Think about wound healing. If you have a wound that is moving, it's going to be regeneration. So if you have an implant that does not have primary stability and it's in micro motion during the healing, what do you get around that? Scar tissue. If you have a bone that is fractured and the fracture sides are moving, what do you form in between? You form a callus that will be scar tissue. So wounds that are moving in a state of micro motion are not going to regenerate, but they form scarring. So if you really want to control it, you want to stabilize it. So we put these sutures and we bond the sutures to the position of interest. And what is that position? Typically at least 2 millimeters coronal to the CJ, and there's evidence to support that concept. But generally, I bring the mid-facial level to approximately the same level as the interproximal in order to have harmony established. So we start out over-correcting, and then during the healing, tissues will retract. And you can see that in some areas that I'm not reflecting the papillae, you see, you can go back at this point and get under the papilla. So this is an older case. These were using older instruments. I didn't have as efficient a papilla elevators in those kits as we have in our VISTA ABC kit. So one thing that you really want to see is that also there's a little too much tension here. The tension is really in this area too much. So we have newer suture techniques that divide the tension among 4 points so we don't have to overexert the tension. So that's also important. But you see that that's the area of the fold that the papilla was not elevated properly. This is ideal. You see that the papilla was elevated properly and it's in the same position at the mid-facial of the adjacent teeth. And I want you to also see how healthy and vascular the area looks. That's the key for this procedure. You want to keep the blood supply. Your eye automatically knows if you have vascular compromise like you have here, because you get ischemia and you want to avoid that. And then you can place the graft material of your choice, and there are a variety of autogenous, allogenic, and xenogenic scaffolds that are available to use. The key is that when we make this kind of a suturing and coronal anchoring, what we're doing, we're creating a space. We're creating a large space right at the cervical area, so there's a lot of room for graft material. And that's the key, because in some of the procedures, you have such little access, you can use small little bits of graft and not enough to make a difference. in a procedure what we call phenotype conversion. So we are aiming for phenotype conversion. We're taking a patient with a thin mucosal phenotype, and we want to make them have thick mucosal phenotype. So we want extra thickness gain. So you see, we put a relatively large scaffold under this tissue, and that area is really filling in. So we're going to be mediating or supporting a phenotype conversion procedure. And then, so it's not rational to take autogenous tissue for all of this because that would be too invasive. But one source of autogenous tissue to which I frequently go to is a tuberosity, because tuberosity is relatively easy to harvest, but also very effective and less traumatic for the patient to recover from. So we take the whole tuberosity, and then I divided it into 3 pieces because I want to feed some of that tuberosity tissue under each papilla to thicken the mucosa of the papilla. I wouldn't dare to call this papilla regeneration because, as I would say, that's not something to which I want to commit myself and my patient to. But tuberosity is the kind of tissue that's dense, fibrous connective tissue, and it actually grows and expands during the healing, as we will see. So we will anchor each of these tissues under each papilla in here to support and try to fill in those spaces. And you can see the patient comes back after 3 weeks for suture removal. You can see that there's been a lot of healing, and the tissues look excellent in health because the vascular supply was preserved with VISTA, and things healed very quickly and eventfully. So then we fast forward 6 months, and we have excellent results. What I want you to see is that I removed about 3 to 4 millimeters of the restoration on patient's right side, and the tissue has remained to the restorative margin. Unfortunately, the restoration didn't have to be changed, and the same thing on the other canine. These were the most challenging areas. But also, it appears that we may have filled in the embrasure spaces where the black triangles were. So unfortunately, I see a lot of misinformation in this area, with some colleagues going around and promoting papilla regeneration. But what I like you to see, the reality of this over long term. But what we have accomplished that is part of our approach is increasing the thickness of the mucosa. This is surgical phenotype conversion, and that is really very important. I know some of the colleagues, especially in Europe, they go for very thin mucosa. They don't like to make the tissues too thick because they look and think of it as unaesthetic to be thick. But in America, we like everything big. So we like big tissues here. Why? Because these are big and beautiful, and they're very, very stable. So I like to make the tissues very thick because I know that comes with stability over time. So here it is, the 6 months follow-up. We have mid-facial tissue coverage and interproximal fill at 6 months. But before we start congratulating and start teaching courses on papilla regeneration, I want you to see the 3-year follow-up, because the 3-year follow-up shows a few things. The phenotype conversion has been very successful because we have thick phenotype, and the mid-facial coverage has remained, and if anything, has gotten better, and the same restoration, the margin is fully covered and looks great there mid-facially, very, very stable. But the interproximal fill is not complete. So that's because the tissue is retracted. Why? Because we have bone loss and we have limited interproximal contact. So how can we manage that? The solution to this is not just periodontal, but it could be orthodontic, which is what was done in this case. Oh, sorry about that. So, which was done in this case by Dr. Gemma Javliana, the restorative colleagues who also performed the orthodontics to perform a little bit of interproximal reduction or IPR to bring the teeth a little closer to widen the contacts to fill in these black triangles. So that's the solution. Or in some cases, people may consider restorative solution to broaden the contact, but very often we use orthodontics. But what I want you to see is this phenotype conversion, which is really at the heart of this, is basically increasing the thickness of the mucosa to give stability to the tissues. So this detail hopefully illustrates how VISTA works and advantages it because it preserves the blood supply. You're separating the mucosa and periosteum together. You're making a wide enough access. You're opening up a window. You can have visual access. You can also have room to place large enough grafts to mediate this phenotype conversion. And then the coronally anchored bonded sutures are really the key for creating stability of the coronal positioning. Because if you just coronally position without these sutures, what will happen is that the patient goes home, they're talking, they're eating, they're moving their mouth, and they are going to have movement of the tissues, and the tissues will never have a chance to adhere. So I like to keep the tissues stable for the first 3 weeks to establish stability and attachment of the gingival margin during the initial 3 weeks. So the important part also is that there's no scar in the areas that we need. The scars can be caused because, let's say, if you make an incision at the papilla, many times you can see those scar tissues. If you make vertical incision, you're going to see scar tissues. But the vertical incision that's vestibular, that incision you will not see because it's above the smile line. But we also have to consider what are the disadvantages and limitations. We have to be very transparent. Yes, this is, I would say, technically moderately challenging, but it is teachable and it's learnable. You have to be committed to learn the right protocol. I see many colleagues do a little part of it, but they don't do the suturing. They may not do their, correct papilla elevation, and they're using periodontal dressing, or they're changing the protocol. So if you really, really want to excel at it, you want to learn the protocol, and you can commit yourself and understand with every new technique, there's going to be a learning curve. You start with simpler procedure and you build on it. The bonded suturing, some colleagues, especially surgical colleagues, are hesitant to use restorative materials, okay? But I keep assuring them, start it, you learn it, and it's easy, and don't worry about it. If the roots are really close together, that may be one of the limitations. Sometimes in the mandibular anterior or in some areas where the embrasure space is less than, millimeter and a half, millimeter, less than a millimeter, sometimes there's so little interproximal tissue that if you try to elevate it, the papilla will pop in that area, so that's the limitation. Okay? So one other thing that I want to emphasize is the work of Alfonso Hill, who did his master and PhD thesis on this project using VISTA. He did something very important to superimpose before and after study models of patients who received VISTA root coverage procedures. And digitally, he was able to get some information about it. The most important information was about root prominence. He was able to show the roots that are very prominent. Those are challenging because the root prominence was negatively correlated with root coverage. So there's a negative correlation. So again, showing that the roots that are flat, that are less than a millimeter sticking out of the tissue, versus those that are really prominent, they're going to have different response. Lack of root prominence or flat roots have 110% root coverage, but very prominent roots have 70% root coverage. So you see, this is one of the most important aspects. So root prominence is really, really key. So I know we're kind of short in time, so I just take you through a procedure to covering implants also, because I know that you want to also see the implementation of VISTA for implant complication. This is done by, unfortunately, by some of the colleagues in Southern California who place these implants too far facially. So we can do the same technique and concepts, and the first thing is to remove the restoration, and you can see how much facially positioned these implants are. And then we can use the VISTA technique, and I'll show you a little short video of making the VISTA. But what I want you to show you is that VISTA is not just an incision. Once you do the tunneling, it actually is a window. You see, you can open this window and you can visualize the entire alveolar bone and tissues around the implant, and see that you can visualize it and you can correct it. And then we harvest the tuberosity tissue from there, and we can place that tuberosity tissue inside, and then you can see you can create a big bulk of tissue. But the key that I want to emphasize is, think of this as a window that you can open up, have surgical and visual access to the area to correct it, and you can go from there to, you know, a lot of bulk created, and then you can correct the defect, and you can go from there to here. And so these are challenging cases, but it is something that is feasible and doable. So let me ask you, Kayvon, should I stop now and go for questions?
Do you have a lot more? Do you want to present something else? Go ahead.
Yeah, I can show you. Also, you wanted to see VISTA for bone augmentation. Here's a case. You can see that this patient has severe bone loss on the anterior teeth. The ridge was really narrow, but so is also the mucosa. So the challenge in bone reconstruction and alveolar ridge augmentation in this area with very thin mucosa is graft exposure, membrane exposure, and loss of graft and failure of the procedure. So we can actually use the same concept using VISTA with what we call modular bone augmentation, or MBA. And you see, after the extraction, typically I like to let the tissues heal. I don't like to do extraction and ridge augmentation during the same visit, because you see that your mucosa will have these big holes in it. But for logistic reason, we did them together at this time. You see, I make a vestibular incision, and through that vestibular incision, we can do a lot of things. We can make a tunnel to expose the area of the surgery for bone augmentation. So you can see that it's very easy to make this vestibular tunnel. And you see that this is a long vestibular incision, extends way down, and I remove all the soft tissue remnants. But also through the same incision, and you asked Kayvon about doing bone augmentation and soft tissue augmentation all within the same incision. Yes, it's possible. You see that we're doing root coverage in the posterior areas to that vestibular tunnel, and it's really important. You see, my instruments are going right on the attached gingiva. I'm not going down in the vestibule where the mental foramen is. So tunneling in the posterior mandible, that's something you have to be very careful about. But then we can also harvest bone from the same area. We are using some bone harvesting devices for removing bone in these areas. And then we can install the moth fix screws. You mentioned about the moth fix. These are modular screws. You see, the screws are very easy to use because they're two-piece. The driver is sitting right on top of the head of the screw. You grab it to give it very stable for insertion. So you see, I installed like 5 screws through that same vestibular incision. But these screws do not have the head, because the head makes it difficult to install. With this kind, because on top of these is a hex, and these hex makes it easy for installation. And then the second part is the abutment that is installed on top of that. The benefit of that is that the abutment is also fixating the membrane. So it's really the concept of the modular screws that makes it easier. So basically, that's what the screw looks like. You see, it has a hex on top of it. The driver fits directly on top of it and grabs it. And then you see that you have the instrumentation for installation of that. And you have a variety of different screws, okay, with different abutments, different heights, and you'll be able to use it for tenting, for block fixation, for membrane fixation. It gives you a lot of different opportunities there. So then you see, after this, you can see, with this technique, we can create a very wide ridge, and this is really possible because we made our tunnel through that vestibular approach. At this point, you can open a flap. There's no problem with implant placement. We place our implants. We also do soft tissue augmentation. This is tuberosity tissues that we place around this area to augment the tissue as well. And you see, we're able to perform that. So that's using VISTA for GBR and bone augmentation, using what we call a modular bone augmentation approach. And that's something that is possible. So hopefully our colleagues took away some important information here. And I'm happy to answer any questions that you may have and have some further discussion with the colleagues. Hope you join some of our future virtual courses, and I'm happy to answer any questions that you may have posed at this time.
Thank you so much, Dr. Zadeh. So first of all, I have to say, Doc, you opened up a can of worms right here, showing all that mud fix and unit fix thing. I wanted to put you on the spot. I want to see if you could actually, whenever you have time down the road, you could give us another webinar or webinar on this mud fix, because I think it's an amazing, genius invention that you have. So you can answer that later, but we would be honored to have you again if you could have something on that for us.
Sure.
A couple of questions, Doc, and it's Sunday, and we want to let you go. First of all, do you fix all your, whether you're using biological, like say PRF, or using whatever graft you're using, you always fix your graft material?
So it's a very important question, because yes, if you want regeneration, you have to have stability. That's one of the concepts of any regeneration, whether you're doing bone augmentation or soft tissue augmentation or any form of augmentation. You have to have a stable and protected space. You make a protected space, and you have an appropriate scaffold, and you have the right signals there, you can make bone, you make a protected space, you can make soft tissues. So stability is the key. So when you're doing VISTA, the most important aspect is to stabilize that gingival margin. And we create a protected space right under that gingival margin using that suturing, so that area is stabilized. So what we put the graft material depends on what is the graft material that is being placed in there. So if I put a very large collagen scaffold, such as FibroGuide, okay, that FibroGuide will fill into that space and becomes basically immobilized, and no need to suture the FibroGuide. If I'm putting PRF, the PRF fills into that pocket that we create, and it doesn't need to be stabilized. But if I take a small piece of tuberosity, that tuberosity is slippery, it can move around, you have to stabilize it right under the papilla. So you have to think about what you're putting in there, whether it's really going to be stable during the healing, and what you need for augmentation. Same thing goes for bone. You know, many colleagues just open a flap, put some particles in there, maybe throw a membrane, maybe they don't, and close the flap, hope for the best. So hope is not a strategy, right? So you have to stabilize that, right? So if you stabilize it, you have to think, how can I stabilize the bone? So you can create a stable environment. So you have to have a stability. That's why we use the mod fix screws to create a protected space so tissues don't compress the graft during the healing, and there's no lateral movement of these particles there. And if you put a membrane, and the good thing about mod fix is that when you put a membrane over that, the membrane gets fixed to the abutment that goes on top, so the membrane gets stabilized and get the space creation. So you basically accomplishing both tasks simultaneously. So yes, you must stabilize if you want to regenerate.
Perfect. Thank you so much, Dr. Zadeh. You know, we enjoy having you so much. I mean, we can go on all day with this. Let you explain to us all your techniques and these amazing instruments and the procedures you have created, and we really appreciate having you with us. It was an honor. I know you're busy, and I know we scheduled this again months ago with you, and you gave us this time. And so again, I'm going to hold you to that. So if you would give us another day with your mod fix and unifix, we would really appreciate that, Dr.
Sure.
Zadeh. Thank you so much.
Always great to see your very happy and a nice face. I can see you getting a little bit of this white hair coming your way, so but you're looking great. I hope my colleagues, for wherever you're connecting, you're healthy, your families are well. My suggestion is, don't be despair during this period. Think of it as an opportunity for self-growth, self-reflection. Take care of yourself, take care of your family, take care of your patient, and hope to see you all sometime in virtually or in person.
Thank you so much, Dr. Zadeh. Again, always, you know, so much positivity, so much energy. Really appreciate you, though. You have a wonderful Sunday.
Okay. Be safe and take care.
Thank you.